Okay, that's been 5 minutes, so I hope everybody who is planning to attend is here. My name is Emma Heiken. I am the Director of Events for the United Democratic Club and also the Supervisor of Community Affairs at the San Francisco Mayor's Office. The United Democratic Club is a pragmatic club that promotes progressive ideas across San Francisco. And every month we host several events and panels to educate our members about different aspects of San Francisco life. And we host political events where we do the work to support candidates that are forwarding a progressive, fact-based, and analytical policies. If you'd like to get more involved in the club, you can reach out to our website at uniteddems.com or info@uniteddems.org. Tonight, we're going to be discussing how community factors impact public health. For the past several months, we've all been talking a lot about public health. It's a term that's entered our daily lives. But our two panelists here have been working on public health since long before COVID ever existed. So we're going to hear from them tonight about exactly what public health is, what it looked like before COVID, and what it's going to look like moving forward. So I would love if our panelists, Kirsten, Bibbins-Domingo, and Brenda Story, could introduce themselves and tell us a little bit about what you do and how your job has changed in the last few months. Brenda, you want to kick us off?
Sure. So I'm Brenda Story. I'm the Executive Director of Mission Neighborhood Health Center. And the health center is a nonprofit, federally qualified health center. We've been serving the Mission District for over 50 years, and we have 3 clinical sites. The bigger site in the Mission, site in the Excelsior District of San Francisco, and we have a specific site to serve the homeless population in the city. We serve about 13,000 individuals and families each year, primarily serving the Latino immigrant community. That's sort of the roots of the health center and our history. So how have things changed? Well, I would say we're doing 2 jobs right now, right? So we're still doing the job of making sure we provide primary care to our patients. You know, if you have a diabetic patient, you still need to see that patient. You still need to do blood work. You still need to try to maintain that patient in good health. And at the same time, we're dealing with the response to the COVID pandemic, and we have instituted some testing in our parking lot, actually. So we're really expanding our efforts to testing members of our community, primarily people who are either symptomatic or who have other high risks, such as living in crowded conditions. So that's how things have changed for us. We are we have moved to about 50% of our visits are now telephonic, which is new for us, and the other visits are face-to-face. So a lot of different changes: social distancing in the clinic, training of staff, wearing masks, and really delivering care in a very different way than we delivered it before.
Yeah, we'll get into a lot more of that in a bit. Kirsten, will you talk to us about what you do and how it's changed in the last few months?
Sure. So my name is Kirsten Bibbins-Domingo. I am a professor at the University of California, San Francisco. I'm a general internist and primary care physician. I practice at Zuckerberg San Francisco General Hospital. I am also the chair of the Department of Epidemiology and Biostatistics at UCSF. So before COVID, I practiced medicine. But I conducted also a lot of research about how and why we have some communities that have a higher burden of disease than others. So since the time of the pandemic, I think that just as Brenda is saying, is that we have been caring for the patients and communities we've generally taken care of at Zuckerberg San Francisco General, but then also have been part of the COVID response. And for me, that has been not only thinking one patient at a time as we do as clinicians, but also thinking as public health officials oftentimes do, how do we think about whole communities and whole populations? And for me, that thinking not only as a practitioner, but also as somebody who interfaces with the San Francisco Department of Public Health, with the State Department of Public Health, and communicating public health messages, which I think is related to, but distinct from sometimes how we take care of a person, one patient at a time, is how do we think about protecting whole populations and whole communities?
Yeah, I think that is a great point and leads into my first question, which is, let's rewind a bit and think about pre-COVID. What was and what is public health, and how does that differ from what a medical professional does?
Yeah, I'll jump in. I think public health thinks, public health is fundamentally about protecting the health of communities and populations. It is about prevention fundamentally, whereas in its classical sense, people see doctors because they're sick and want doctors to fix them in some way. I will say as a generalist, I also believe in prevention, and I'm doing prevention when I counsel patients. But I do that generally one patient at a time, and public health is really charged with thinking about that across communities and populations. One of the things I love when people talk about prevention is that the way you know it's working is when nothing happens. And so that is one of the hallmarks of prevention. And so public health classically is making sure we get our vaccinations and promoting, making sure we wear our seatbelts and making sure that laws are there to protect our workers in where they work, all of those things. But when you know public health is doing its best is when nothing is happening and people are going about and living their lives in the way we would all hope.
Yeah, and I suppose conversely, you know it's not working when you notice.
Exactly.
Brenda, you have anything to add about the difference between the public health folks on your staff and the medical professional folks?
Yeah, well, just to add that public health is really broad, right? Because it also includes things like clean water, for example, right? So some very basic human needs, so to speak. I think at the health center, in a primary care clinic, you have a little bit of both, right? Because immunizations, for example, can be considered a public health approach. Prenatal care, to me, is in a sense, it's a preventative intervention. In some of the services that we provide, like even HIV care, has a component of public health, because we know that sort of the global idea is that you want to suppress that virus so that you kind of reduce the ability of the virus to propagate. And then, nutrition education is another example, I think, of some preventative services that we provide. So I think in a clinic, you can sort of have both. You have the prevention of disease, and then you also have trying to sort of slow down progression of disease.
Yeah, that's interesting what you say about HIV care, because clearly public health is important for healthy people, but it's also important for people who already have some sort of affliction and to make sure it doesn't get any worse. Mm-hmm. So public health, a lot goes into it. As you guys mentioned, nutrition, vaccinations, clean water. What are some factors that contribute to public health that a normal person might not know about or might not think of?
Well, I think that there are many things that as we've been thinking about how to communicate about COVID, that I realize are things that we take for granted because they're public health successes. And I think, let's just take an example in California. So in California, we probably have the lowest rates of smoking in the country. We generally don't have it's generally not socially accepted for people to blow smoke in each other's face. So even though we have smokers, they're generally not blowing smoke in your face. Those sort of, right, those are sort of public health victories, right? Those are basically taking what we know about the dangers to the individual and saying that if we're going to live collectively as a community, we have to basically communicate to people about the dangers of smoking. We have to make sure that there are other types of restrictions and generally cultural norms that we say, you know, it's probably not good for restaurants to have smoking sections because that doesn't make any sense. And for the sake of all of us and our collective health, we want to make sure we give smokers what they need to stop smoking. We want to make sure that kids don't get started smoking. We want to have laws and restrictions to prevent that. We want to make it sort of culturally acceptable that we don't blow smoke in each other's faces. And those are the same types of ways in which public health, I think, approaches it, as we now are trying to make a norm in how we think about wearing masks, right? And so that it's just a regular thing that we are all doing because we try to keep each other healthy. We do this to protect ourselves, but we also do this to protect each other in our communities, right? That's an example.
Yeah. Brenda, I know when we were preparing for this event, there was some factors that we had spoken about that are non-obvious contributors to public health.
Mm-hmm. Yeah, I mean, I think what Kirsten just spoke about, in a sense, is to behavior, right? But I think, you know, it's social factors like housing, right? So we're thinking about COVID, and we're thinking about people who test positive, how you want to be able to isolate them from others for, 14 days, right? Well, we just got a gentleman come in to us, needing some resources to pay for his rent. And we asked, well, how much do you pay for rent? He pays $325, right? But he pays $325 because he lives with another 10 people in 2 rooms, right? So the rent is really $3,500. But all people can afford is very limited amount. So you have the situations where people really live in congregate living. I mean, in this case, it happens to be an individual, but we know the same thing about families, right? You have a family of 4 or 5 people really living in a single room occupancy hotel as an example. So when you have to quarantine or isolate an individual, it can be very difficult for them. We've also heard stories where people are afraid to tell others that they live in because they're afraid to get kicked out. So these are, the whole housing situation, right? And the economic resources that people have really impact addressing a pandemic like the one we're addressing right now. As one example.
Yeah, I think to your point, Brenda, I'm curious, when we think of health, we think that as an individual, you have so much control. I can choose to go for a run or not. I can choose to smoke or not. So to what extent is an individual in control of their own public health?
Probably to 40%. No, well, in their own control, maybe 20% the behavior, right? Because you can control your genetics, You're going to have the genetics, you're going to be grow with. You can't really control your environment totally. You can control it to some extent, but we can see what's happening with our environment, right? I think a lot of low-income families, for example, might be in living situations where they might be exposed to toxins. A good example of that is lead. So for many years, you had children in low-income families exposed to lead, which can be quite harmful for children. And it was because of the living conditions that they were in. So that you cannot, totally control. Racism and discrimination, that's sort of hard to control. That's another example. The economics of your family, right?
I'm curious, can you talk to me a little bit more about how can racism and discrimination affect your health?
So I think it affects your economic opportunities, as an example. I I think it can affect you from the perspective of stress and mental health. So sort of experiencing discrimination and racism on an ongoing basis, or even as a child, right? Why are you different? Why is somebody calling you something? What are the pictures that we see on television, for example, or what is all this hateful speech that is happening day by day that people get exposed to, can really affect, you know, your stress level. And we know that stress can really affect your health. So, you know, these are sort of more of the social factors and the indirect determinants to health status.
It's interesting, those social factors can also lead you to make personal choices that are not as healthy. So, you know, maybe you don't fit in and so you start smoking to fit in, or you don't want to go outside, you don't go for that run because you're afraid of being made fun of in some way. And Kirsten, yeah, go ahead.
I think we oftentimes, it's a fairly American phenomenon to emphasize personal choice and personal responsibility. I think the challenge is that for many of these things that we're talking about, we are talking about individuals, families, and communities for whom their choices are constrained by these other larger structural factors related to racism and economic inequality, right? And so if you live in a neighborhood, when I was a very junior doctor, I talked to my patient about eating fruits and vegetables, and he came back and he said, "Doc, you would be so proud of me. I am doing this every single day." And he showed me this can of vegetable soup that he bought from Walgreens, and he ate it religiously every day. He's somebody who had heart failure. He was consuming an amount of salt in that can of food, which was exactly the opposite of my individual counseling to him. His choices are constrained because of where he lives. Where he lives in San Francisco is, if we look at the history of redlining in the Bay Area, if we look at the history of economic opportunity, we can talk about the individual choices to eat fruits and vegetables and to say some people might choose not to. But I think then we are ignoring the type of larger structural issues related to racism and poverty that both constrain choices for individuals, but really are the factors that then, through additional means, as Brenda talked about, actually affect individuals' health in these other ways.
Yeah, and I think, so you touched on it a little bit with redlining. And so, you know, people are now becoming familiar with food deserts, something that public health officials, we've known about forever. So what are some other ways that public health can look different for different communities? You know, from the Marina to the Excelsior, how does public health differ?
Yeah, well, I'll just say, so let's look at COVID. If we look at the map in San Francisco for COVID-19, on average, we are doing pretty well in San Francisco. And if you look at the map, that means we virtually have no cases on the western part of town, and almost all of our transmission is in the eastern part of town. So what do we conclude from that? We could say, these are people who don't want to wear masks. These are people who are whatever. The reality is, when we look at why we have transmission, particularly in our Latino populations, who about half of our cases in San Francisco are in Latino populations. They make up 15% of the population in San Francisco. It is an issue of the economic necessity to be out and working. These are the essential workers that we talk about. These are the people who make it possible for the rest of us to shelter, frankly. And being out and working, then combined with coming home and not having other living options that would allow you to be separate from family members, or as Brenda said, into oftentimes because of the economic realities in San Francisco, being in really densely populated housing, means that transmission is really much more challenging to even get a hold of. The New York Times early on in the pandemic did this wonderful analysis with cell phone data to really show that it's a luxury to shelter in place, that in poorer parts of town, richer parts of town, people shelter earlier and they stay sheltered longer. And in poorer parts of town, it is harder to find the places to be inside because of necessity to be out. And the necessity for food, the necessity for paying the rent is the things that drive you back out. And that luxury to shelter is one thing that when we issue our public health messages of like, you should shelter in place, ignores what is the reality for many, many in our city, and is something that we have to then think of other ways to deal with. One of the things I'm really proud of in San Francisco that other advocated for is to protect the, to provide resources while people are isolating and quarantining. And that's an example of understanding the need and the realities in terms of what's required in particular communities, and then adapting our public health and policy approaches to meet those needs.
Yeah, I think that's really a great example. Brenda, do you have an example of maybe another public health issue that's not COVID related that we can really plainly see the differences in different communities of what their public health looks like?
Well, I think access to health is one of them, right? I was actually quite surprised that, UCSF did this study. So they did this massive testing, right? And one of the things that they found out was that a lot of the Latinos who tested were not connected to healthcare. And frankly, I was surprised because San Francisco, being one of the richest, I think, counties in terms of access to healthcare, you still have that as an issue. So I can only imagine in other parts of the country, we know that, Latinos have the highest percentage of being uninsured. So if you don't have access to medical care, then you don't have, the ability to monitor your health, and to have a lot of those preventative services that we spoke earlier were important. So I think that's another dynamic that we're kind of seeing. Or even, people, one of the things we're doing when we test people is, first of all, a nurse calls them when they're positive, and then we're following up 3 days later. Because our community or individuals don't necessarily know how to gauge their symptoms, right? And how to know, oh, it's time for me now to, I'm really getting very sick. Let me sort of move, call my doctor or call, the hospital or go to the hospital. We had, unfortunately, a patient who died at home, and you have to wonder, did they not know how to self-monitor, take their temperature, be able to have a pulse oximeter at home, right? So that they could sort of monitor themselves. So I think access to health is key. Access to a medical provider that they can sort of consult with would be another example.
And to your point, a lot of people in the Latino community may not have access to healthcare because they don't have legal status in the country, therefore don't have a job that provides benefits, which obviously is a privilege to have an employer that will provide that. I do want to remind folks who are tuned in that you can submit questions via the Q&A button, and we'll get to those at the end. So please submit any questions you have for Brenda and Kirsten. So we've talked about these issues between these different communities of how it's grossly unequal. Are there any policies or programs that are making a real impact on creating more public health equity?
Since I just talked about access, let me mention those. So I actually think we have been, if we look retrospectively at policy in California, right? I mean, and let's start with the Affordable Care Act, right? So the Affordable Care Act as an example, together with that, we had the expansion of Medicaid for the adult population. People 18 to 64 before could not, participate in Medicaid. So that's a big expansion that we saw there. Similarly, then in California, we were able to pass legislation where undocumented children were covered now under Medicaid. So that was another success, another battle that we won. Locally, actually here, Healthy San Francisco, I think was a great program. It's not health insurance, but it really helps people connect to healthcare. But even within Healthy San Francisco, we had to do some advocacy to cover people 65 and over who were undocumented, and we were able to do that. Now we were about to get that success in California of expanding Medicaid to undocumented adults over age 65. And unfortunately, because of COVID, that has been put on hold, right? Because of the state budget. So I mean, I think those are some of the wins that we have had at the state level in terms of access to care.
That's great. That's great. Kirsten, are there any policies or programs that we should be looking out for?
Yeah, I think that that when I think of my faculty who study what we call social epidemiology and think about the social determinants of health, there are ways in which the root causes in the end still come back to poverty, education, and understanding and those factors to mitigate racism. And when I think about to me, the most important things are related to how we protect a living wage for everyone, right? To the extent that people have resources, they then have resources for health. To the extent that we make sure that we protect education for our children, that those end up being the most important factors for how for those intergenerational effects, and also for how those patterns of poor health start earlier, and they're directly linked to educational opportunities. And so I think there is a way in which, Brenda, I would 100% agree with what Brenda is saying, that access to healthcare as a right is important. But there are ways in which our broader policies that relate to economic and educational opportunities are themselves health policies in the end, because those are the most important things for ensuring health in our most vulnerable communities.
Yeah. As a public health student in undergrad, I do recall studying, if you improve anybody's success at anything, their health will improve, whether it's
absolutely
access to the internet or making sure they can speak English decently. No matter what, their health will improve.
Yeah. And conversely, when we ignore that at each of these levels, I think they compound themselves, right? So if to the extent someone's job stability is vulnerable and they now will lose their job, they have all of the economic challenges, then they can't also afford to get health care, or can't afford to access healthcare because healthcare is only tied to their job. They compound in many ways. And because we're talking about in San Francisco and in the Bay Area about an area that the economic strains on individuals and for families have an impact on adult health as well as child health, you see how these are then compounding into intergenerational effects as well, which has been well documented.
Right, like as you said, if you have extra money, you're more likely to go get medical care. If you can't even pay rent, you're definitely not going to get medical care.
And I think that's what they find, people who study what it means to take a family that is homeless and house them, or the difference between a family that is that has a job insecurity that has a job. Oftentimes the things that they spend those extra discretionary resources are on all those things that we would think about as being things that are related to behaviors, important behaviors for health. So better food for the kids and things like that.
Right. Or a breast exam to make sure you don't have breast cancer or whatever it may be. What is something, so our club is well known for wanting to get involved in making the world a better place, and especially San Francisco. So what is something that one of our members can do to help the public health of all of San Francisco? Besides not smoking.
Well, I would say that the need right now during COVID-19, and not to just bring it back to COVID-19, but we're in a twin pandemic of economic hardship as well as COVID-19, and it turns out those same factors are playing themselves out in exactly the same communities. And so I think there are ways to be involved in literally providing relief, in being involved in investing in community organizations that have really been the pillar in the communities that are most affected, and in thinking about the policies that really support and protect those people who are working at this point, I think we need voices supporting those types of policies, as well as direct investment, both for relief as well as ongoing sustainable support in the communities that are disproportionately affected, because both of these pandemics are affecting the same part of our region and our state.
Yeah. Brenda, what can we do to help?
Yeah, I mean, I would agree. You know, it's interesting. We talk about economic inequality, and made me think about the Stockton initiative, where they were giving a number of families $500 extra, right? And this was pre-COVID. And then really, what were people doing with that, and really how the quality of life improved for an individual just by getting those extra $500 a month, right? And I remember the story of a grandmother, and what she was using her money for was to spend time with her grandkids, right? And be able to take them different places. So that enriched her life from the social perspective, but it also enriched the children's life, right? So the successive generations. So I think looking at things like that, but really at a California or a national level, I think we really need to look at economic equality from a national or at least a state level. Because what happens when you just do it at at a city level, I'm not saying we shouldn't, but it doesn't impact everybody, right? I have families who come to my house and are from Richmond, so they won't be able to get the help, but the ones that live in the city get the help. And as we know, with the gentrification that we have had in San Francisco, many low-income families are moving away, which brings me to, I think, the other area of advocacy is really affordable housing, right? Mm-hmm. We really need to have deep affordable housing in San Francisco. I mean, what we have is we have a lot of workers who don't make enough money to live here, and they have these horrible commutes, right? 2-hour commutes to get to a job in San Francisco. And it shouldn't be like that. I mean, everybody who works here should be able to afford to live here. So, I mean, that's another disparity that we kind of see.
And to get that back to COVID, so many of our essential workers at the grocery stores can't afford to live in the city, so then they're forced to ride public transportation, further putting themselves and other riders at risk every day.
Including many of my staff, yes.
So are there any organizations in San Francisco that are spearheading public health advocacy besides your own?
I think there's multiple groups that sort of engage in different aspects of public health advocacy. And what I would say to the audience is really finding the group that and the issue that you can be passionate about, right? Exactly. And just engaging with that agency, engaging with that community. If it's about food insecurity, then engage with that. If it's about access to healthcare, then engage with that. If it's about affordable housing, engage with that. And really sort of becoming active and getting to know the organization and the people that get affected by it.
I think
I would agree.
I think that's a good point, because we're so focused about November, getting out the vote. People aren't going to go to the polls if they're afraid of COVID, or if they are afraid for their health for some other reason. So it really, negative public health can infect all areas of your life, from your representation with the government to your relationship with your family, with grandchildren, spending time with your grandchildren. It's all encompassing. Go ahead, Kirsten, sorry.
Yeah, I'm just going to underscore the same points that you both are making, and Brenda made very well. It's is that, in many ways, the time we're living right now is a time that reminds you how these are global issues, they're national issues, but the response is probably very hyper local, right? And I think the ways to be involved, the need is so great that being involved in with organizations that have been working on the ground in these communities for a long time, or in your own community for a long time, to understand the need. We're particularly focused in this in our Latino communities, in particular in San Francisco. But the need during COVID, I think, really spans a lot of more vulnerable groups, even seniors who are more isolated. So my recommendation in general to people is this is a time when to identify whatever you're passionate about, organizations that work in that area, and to really get involved. And to speak to your point about just getting people to exercise their civic duty, that is also associated with good health and engagement in civic life. And I think that is another thing that is best when we start very local in terms of the things that we're passionate about and are important. And I think that's the best way to start.
Yeah. Another topic that's been really at the forefront of political debates locally, nationally, and what people have been talking about a lot is mental health. With Mental Health SF newly being funded, and everybody, embracing a little bit more self-care in the last few months, what role does mental health play in public health?
Well, for health, there's no division between physical health and mental health. I think we only have a division because we, in healthcare, parse it in different ways, and we have different providers, or we reimburse differently for these things. But there's no real difference as we think about the health of an individual or community and mental and physical health, except that we probably have ignored mental health and underfunded mental health for so long. It's a particular concern of mine during a time when we are refocusing our resources to the pandemic, when we are now forced by the pandemic to oftentimes do our visits in other ways that are more challenging, telehealth, important and good for reaching, but also maybe not as good for connecting in all of the ways and for all of the conditions that we've not actually been that good in addressing. I think it's important to keep mental health at the forefront, especially also at a time when the public health mandate to socially distance can sometimes lead us not to be able to connect in ways that are important for mental health.
That's why we're doing this online.
Yeah,
yes. Some things are better, right? Because we can reach more people. That is an advantage. But sorry, go ahead, Brenda.
Yeah, no, I would agree. And, I think the other thing to think about mental health is we need to think about it as a spectrum, just like we think about in regular, in general health, we think about prevention and we think about interventions. We also need to think about mental health in the same way. And I'm not sure that enough attention is given to that more preventative aspect of mental health, especially, I think, in disadvantaged communities, right? So, how do you teach people how to deal with stress? How do you teach people how to deal with sadness, which we all experience, right? Everybody, experiences stress, sadness, has the blues or whatever. So how do you teach people to cope with those issues, especially those that are sort of having these challenges and stressors on a daily basis? So I think when we think about, we need to think about mental health, and then we need to think about mental illness, right? Which is, a spectrum of disease that we also need to understand and treat and bring services to. So we need to bring services on both sides of the spectrum, the preventative and then the treatment of actual mental illness.
Yeah, I think one thing that always stuck with me was learning that people who have strong community automatically have better health outcomes. And whether that's a church group or an AA group or your grandchildren, those just always lead to lower rates of any issue you may face later. Mm-hmm. So, my takeaway was I should hang out with my friends more. And during COVID, that's obviously not an option. I anticipate we'll see some really negative health outcomes down the road that are not explicitly COVID related, but are isolation related in some ways.
Yeah, I think we're already worried about that. So I think you're right. I mean, we don't even like socially distance, when really what we're talking about is physically distance. And I think the challenge of this time is to be more socially connected, to be more socially connected in ways, and to figure out how, even though it's not ideal, to use our technology I worry a lot about seniors. You know, we talk a lot about the toll of this pandemic. It's a real challenge with seniors. We've talked about nursing homes, but there are so many other ways in which general senior services are now not as, we can't sort of start them in the same way because of you know, more concerns about health. But I think the isolation, even among seniors, even among people who are younger but don't live in community and can't connect in the same way, I think that that's the real challenge, and to be mindful of that. And I love how Brenda said that, to both think about prevention and for those people for whom mental health or illness is a more concern, to get treatment, but also for all of us to think about attention to mental health, I think is important.
I hadn't thought of it that way, as it's the same as physical health, preventive care, and then, you know, interventions. That's very true. And so, yeah.
And, you know, I think post-COVID or during COVID, we really also have to be thinking about our children, right? I mean, it's interesting. I was walking down my neighborhood and there's this little girl crying to her father, right? Because she wants to play with her girlfriend. She's tired of playing with the dad, right? Says, yeah, I want to play with my friend. So with the schools closed, right, we also need to be thinking about how our children are coping with that, right? Yes. And what interventions can we bring to address, from that perspective, the mental health of children and what they're experiencing, right? Yeah. I mean, one of my staff, her little boy, says he hates COVID, right? He's tired of COVID because it keeps him away from that socializing that is so important in children's lives. So, so we're gonna have to think about mental health in a very broad, I think, perspective as we deal with this pandemic. Yeah.
So obviously there's a lot of work to be done on, you know, especially with our children and with our seniors and all of our mental health. Are there any cultural norms or public health initiatives that have been implemented because of COVID that you think we should continue?
Well, I think, so to me, COVID, this is the glass half full, glass half empty type of thinking. So I think COVID offers the opportunity, the urgency around COVID means that people have been thinking a little bit more creatively, right? So I think that thinking about how to protect wages for workers, replacement wages, I think is important. People thinking about how do we mobilize for our homeless populations or people who don't have housing to shelter or isolate, right? Those are actually in the mindset of the way we're normally organized. That's bringing people in healthcare, people in public health, and people in the housing sector together in a way that we all have to think about as a city. How are we going to address this? So I think there have been a lot of great community initiatives. I think when we did the testing in the mission, UCSF did the testing in the mission district. We partnered with community-based organizations to think about they use the data that we were able to generate from that testing to advocate for other types of things, which is, I think, really powerful. The challenge for this, to me, is how we sustain it. How do we take that thinking outside the box because we're responding to a crisis, to then say, let's build sustainable solutions, sustainable partnerships that can really say our housing issue is not just how do we get somebody who has COVID to isolate and get them housing for a short term, but how do we think about the longer term sustainability options? And that's where I think we want to be able to harness that creativity to think then about the more sustainable solutions.
Yeah, I love that idea of, you know, public health isn't just for doctors, it's also for community organizations, it's also for, you know, housing advocates, many of whom are on this call. And I love that could be a solution to other, you know, other worldly problems, whether it's educational inequities. That should be something that public health experts are looking at, and education experts, and all kinds of, and religious experts, all kinds of experts can provide a really unique opinion on any issue. What do you think, Brenda? What should we keep doing that we've started to do?
Well, I think, you know, the collaboration around a public health emergency, right? I think one of the things that in addition to the positive side, right, the glass half full, I think, is that we have come together and we have sort of used innovation and we've seen community collaborate, including, UCSF, the Department of Public Health. That's the glass half full. I think the glass half empty is how unprepared we were. I think both nationally at a California level, and then it trickles down right to the county and city level. So, there's been a lot of talk about how public health has been defunded throughout the years, how it's not given enough importance. And, so hopefully one of the things that would stay is sort of the understanding and the urgency of really having emergency preparedness, because we haven't had a pandemic in 100 years, right? But that doesn't mean it's not going to happen again. So I think we need to be better prepared, and that preparation needs to include the collaborations that we have seen, right? So that we can really all together then sort of respond to the health issues that can come up.
Yeah, I think that's that. Maybe it's naive, but that gives me hope. If we were able to really collaborate really well on this issue, maybe we can fix everything else that's going wrong. This pandemic has really helped us look at other countries, and our American exceptionalism is shrinking every day. What other countries, maybe not in regards to COVID response, but what other countries have really sound public health systems, and what is it that makes them sound, and what ideas should we steal from what other countries?
Well, I'll give two examples. I think we can learn a lot from other countries. I know we believe we're exceptional, and I think that, but we can learn a lot. So I've thought a little bit about the continent of Africa, and people have been worried that if there were to be large COVID outbreaks, that a continent and the countries that have less resources would really be devastated. And I think there's reason to be concerned. On the other hand, ironically, many countries that have fewer resources invest more in public health. They invest in making sure they have effective mass vaccination campaigns because they don't have doctors who could treat everyone who's going to get sick. They invest in thinking about how they could respond quickly to a particular infectious disease outbreak. And so I think if you see a lot of the early ways that many countries that we oftentimes think of as having the least resources have responded, it's because they're very used to thinking about public health. They're very used to thinking about mass campaigns for certain types of things in a way that I think our healthcare system, probably our underinvestment in public health and continued funding in our healthcare system has made us, has probably makes us blind to that fact, that other places that don't have the healthcare system probably invest a little bit more.
It's very interesting. Yeah, and Americans have the conception of, it's my body, my choice, and that's true for, reproductive rights, but that can be detrimental for other issues of, smoking and eating fast food all the time. That can lead to negative public health outcomes. Brenda, what are other systems or countries that are leading the fight for this?
Well, so in addition to universal health care, which many countries have, right? I like what Kirsten said, and it reminds me, that a lot of countries have like popular education, right? So they have really found methodology where they really engage community, or they actually go to the community and involve the community in coming up with the answer, right? I mean, the, Paulo Freire perspective of, go to people, ask them what they need, and, how best you can help. So that's an example. I mean, so they really find innovative ways of being able to communicate important information, like, how is COVID transmitted, as an example? What are basic ways of preventing it? And I think in this country, we're a little slower at instituting, some of those sort of innovative ways of addressing in some ways what it might be low literature levels, right? So that there can be very creative in terms of doing that. And the other thing I would say more related to COVID is that I think in some countries we really saw a strong national approach to addressing the epidemic.
That sounds nice.
Huh?
That sounds like it would have been nice.
Yes, yes, and here we've had more this sort of subdivided approach, and I think we really need a national approach to addressing this.
Yeah, and I think I would also say that I think that in countries that have had stronger social safety nets, it has been easier. It's pretty clear, and you've heard Tony Fauci say this, that in many countries, we definitely have experienced the harm and the frustration, and we're all bummed out about sheltering in place, but we hardly locked down compared to many countries in Europe. And one of the things that allowed them to really shut down is because they had many of the people didn't have to go out to forage for food or other types of things that drove people out of the house. And I think that in many of these countries there is a stronger social safety net. I read somewhere, I don't know whether this is true, I read somewhere that in New Zealand, when they shut down, they also gave people resources. They basically said, they actually provided them resources to ensure that everyone would actually sort of be at home and would not be wanting for the things that they needed for the month or 6 weeks or whatever that they shut down. And I think what you see here is that what we know from what would make it good for managing from a viral transmission perspective is exactly what's hard in our environment, because all of those things that make it hard for people to shelter, to stay distance and whatever is because those needs are so wanting in many of our communities, and we don't have the types of support to ensure that everyone could do that. Yeah,
I think it's interesting what you guys said about the cultural competencies of, making public health messaging really culturally competent, and that can be a challenge across the U.S., especially in San Francisco, because there's so many diverse cultures. The way to say cover your mouth is going to be received differently for the Latino population versus the Chinese population versus different populations. That I'm just imagining could be another factor making our job a little harder. We did have one question from the audience about schools and like how to balance the need for children to socialize and learn in person with the need for families to be sheltering in place. What's your advice on how to handle the never-ending school debate?
Yeah, in my view, I think we right now, we're in the month of August. Traditionally, schools start in September. Our responsibility now is to do everything we can individually and countywide to make sure that community transmission is low enough that we can get our schools open. And it's for me not reasonable to even talk about indoor dining bars and restaurants and things like that, because everything in a civil society that's in August should be to make sure community transmission is such that kids can go to school in September. That's, to me, is the first thing. And the second thing is, I think what you're seeing at the state level is supported by the epidemiology, that probably primary schools, K through 6, I think is how they've issued this. Those are probably environments where you're not going to see the types of transmission that makes us concerned among high schoolers. And probably we should be aiming for erring on the side of having those schools open, because they are so critical and foundational for the health and well-being of children in so many ways. And I think that is the direction that you see it. So from an individual perspective, let's make sure we keep our transmission low so we don't have spikes. And then probably the K-8 schools at the primary schools, I think you'll see a lot of move to make sure that they get open.
Yeah, I mean, I would say, I think I don't have all the details, but the idea that San Francisco have around these hubs that they are looking at, so really kind of tapping children who might have high needs and bringing them together into a hub and really supporting their learning. I think it's important because what we worried about is many of our families, for example, they don't have Wi-Fi, so they might not be able to, or the parents are not really able to really help the children in terms of the computer technology, or the parents are working and it's the grandparents who are taking care of the children, right? And they don't know how to manage the technology to really help a child in their learning. So, I think we really need to have a very sort of hands-on proactive approach in terms of saying how can we help each and every child, if they're not going to be in a hub environment or in a school environment.
Yeah, I think that's a really good point. And I like what you said, Kirsten, about we can each individually do our part to make sure these kids can go back to school. And I think that's the one really beautiful thing that I've seen come out of COVID. And, having worked in public health, I'm kind of like, oh, people are getting it, is those posts on social media that say, my mask is me saying I love you, is I can do things that help both of us. And that is true of so many things in public health. And I think people are starting to get used to that a little bit more. And so I'm hopeful that that will, lead into the future about all kinds of topics. It is 7 o'clock, so I'm gonna wrap us up here. Thank you so much, Kirsten and Brenda, for having this conversation with us. And I hope all of our attendees walk away with a little bit of idea of what public health is. Throughout August, we're gonna have several more events planned, including a phone bank for our endorsed candidates for Supervisor Marjan Filhauer, Danny Souter, and Asha Safai. And if you'd like to get more involved with our team and help us promote effective public health policy in San Francisco, you can visit our website, uniteddems.org, to become a United Dems member. And we look forward to seeing you at upcoming events. And thank you guys all for coming tonight.
All right.
Thank you. Be well.
Everybody.
Bye-bye.